Are you ready? Okay. Welcome everyone to the annual lecture series of the Center for Philosophy of Science. If you don't know me, I can't see you in the back. I'm Sandra Mitchell from the Department of History and Philosophy of Science, stepping in for Edward Mashry, the director, who is on a plane or on his way to a plane to go somewhere to give a talk. So it is with great pleasure, but before I have the pleasure of introducing our speaker, let me just make a couple of announcements for the center. Next Tuesday, Nora Hengel will be giving the lunchtime talk on navigating publication bias, reflections on knowledge practices in judgment and decision-making. A week later, Alexandre Billon will be giving the lunchtime talk on the 11th on depersonalization, derealization disorder, the philosophical take-home message. And in addition, there's a workshop coming up that the center is sponsoring on February 15th and 16th, the philosophy of particle and high energy physics 2-2. And everyone is invited. Look on the webpage and register. And all these events are open to the public. So now I have the great pleasure to introduce Dr. Maureen Lichtveld, who I've had the pleasure of sitting on a panel with in the past. She is the Dean of the School of Public Health here at the University of Pittsburgh. She's also the Jonas Salk Professor of Population Health, a Professor of Environmental and Occupational Health as well. She is a leader in the field of toxicology and public health, of disparities in the population and exposure and risk to health, and in the structuring both the public communication. I'm giving a discursive rather than the list. Both in communicating to the public and working directly with the public in developing studies for exposure. She was, before she came to Pitt, she was at Tulane, where she was involved in disaster relief efforts as well. And the Deepwater Horizon, what was it called? Deepwater Horizon. Gulf oil spill was one of the things that she was involved in. She has worked. I think what I've been so impressed by in knowing Dr. Lichtveld is that she covers every aspect related to public health, and especially in her efforts at the School of Public Health, where she led an effort to increase the population. Now I'm fill in the blanks. The population of students in ways to reach more communities in our country and elsewhere. She has done so many things that I think I'm going to leave my list at that point. She has many honors. She's written wonderful papers. She's done incredible, groundbreaking research. But she's also a leader in the education of the public and in the education of students. And so, with that, I'm going to turn it over to Maureen to engage us in her ideas and discussion. And I welcome her to our community.
Thank you. Glad I'm seeing someone with a mask on. Thank you for doing that. Because you're protecting us and you're protecting yourself, right? It's really an honor to be here. I'm hoping my voice carries for you and for you. You know, I always get worried when I'm asked to present in areas that might not be close enough for me in terms of my expertise. And I particularly asked myself, where do I fit? What does public health fit in the world of philosophy or the philosophy even of science? But every time I'm, encouraged to say, no, you should do it because it kind of fits. So you will give me a grade after this, okay? To see how close I got. What I did learn this afternoon during lunch from 4 phenomenal PhD students in the department is that there is no course on the history of public health and the philosophy of that. And I'm going to work on that. That is just not acceptable. So we're going to work on that. Okay, I have friends in the audience who will keep me honest. So I wanted to go back and think about, so how does the philosophy and the history links with what we do in public health? Here are the 10 great public health achievements. I'm sure you've seen them before, and I want you to notice what number 1 is. Without question, it's vaccine preventable diseases. Without question, and these are facts, I didn't make them up. Prevention and control of infectious disease, yes. We remember the pandemic. We currently have 3 infectious diseases traveling alongside each other, right here in Pittsburgh and right here in Pennsylvania. COVID still, RSV, and the flu. And there is a 4th one coming up. That's pneumococcal meningitis in students. Tobacco control, we've made progress there. Maternal and infant health, we are around us, not too far from us, we have the 2nd highest maternal and child mortality in Black pregnant women. Motor vehicle safety, there are still places in our country where wearing a helmet is not a macho thing to do. Cardiovascular disease prevention, it is preventable. We can begin early to see what we eat and how we eat in terms of how we feed each other and feed others during a 24-hour span. Occupational safety, I'll come back to that in a minute. Cancer prevention, yes, there are preventable cancers if we detect them early. Childhood lead poisoning, when as an environmental health scientist, I moved not too far from campus here, and I discovered that I had lead piping. I live in a lovely house that I think is a lovely house. I didn't know that with that lovely house came lead piping. And then public health preparedness and response, and we'll talk about that as you've heard. So let me begin with where I was going and where I will be going, and what's a risk-benefit analysis, and what are some examples in my world of environmental health. So we have to choose between potential nitrate exposure and from lettuce and spinach in children. So do we feed kids the lettuce and the spinach, risking the nitrate exposure, or do we not? Those are decisions, those are risks and benefits that we weigh. Do we accept drones to help us navigate the accuracy of what's happening in the air? We just had a really tremendous strategy in DC at the DC airport. But do we accept drones as a tool to avoid those accidents? Do we use hand hygiene at airports to prevent global spread of epidemics? I am known to actually pull people back into the bathroom to wash their hands when I'm in there and I don't hear the faucet go. I've done that. And then benefits and risk of using antimicrobials in food-producing animals. And we're going to talk about that in a lot more length. Here are some other examples. building up of acrylamide in potatoes and in cereal. Health trade-offs of drinking coffee. Now, I do drink coffee. I'm not going to ask you to raise your hands, but there are trade-offs for that. Eating red meat and the red meat cooking practices. I come from I'm part Dutch, so people eat raw tartar. They love that. In my family, they eat beef carpaccio. So what do I do? What's that risk and that benefit as we make those decisions? I do not do sushi. Potential effects of breastfeeding versus formula. There is one tragic story that I need to tell you. When I started practicing in the Amazon rainforest, I shared part of my life with the students during lunch. There was this idea that because formula came from outside of the country, it was better than breast milk. And so women stopped giving breast milk to their infant. But because formula is expensive, and when they couldn't afford it, they diluted it. And so we had malnutrition in a cumulative fashion, right? And taking away the breast milk and diluting the formula. But a lot of what risk-benefit analysis is about is how we perceive the risk. So how each of us perceive the risk. If a risk is voluntary, and I always give a very bad example of that risk. When the stoplight goes to orange, what do you do? Okay, you know where I'm going. Yes, I didn't stop at times. That's a voluntary risk that I'm taking. When it's under my control versus when it's not when somebody's imposing it on me. When there are clear benefits. When there are little or no benefits on the other side. Particularly also when it's unfairly distributed. If I would take the half of this room and say, okay, I'm going to expose you to ethyl methyl terrible, and this half not. Now that's clearly an unfair distribution, right? When it's natural or when it's created by humans. Now I'll come back to some disasters that are not so natural. When we can count it or when we can. When it's generated by a trusted source. Now, if I put one of these chairs in the hallway and I pretend there is a fire alarm, we're doing a fire drill, and I ask you to hop over the chair and go, you probably will follow my instructions and doing that, some of you. Many of you are smarter. But that's because I said it. Now, if another colleague of you said it, you would say this person is crazy. But you might also say that I'm crazy, which is totally fine. If it's a familiar risk, not really paying attention to how orange is. But particularly, we are more accepting if it's harmful to adults versus harmful to kids. I can tell you don't touch my kids. And in this case, in my case, also my grandkids, because I will become, a murderer. So when we look at, based on our individual risk, our perception of the risk, we make a decision. We make a decision to take action, jump over the chair, eat the carpaccio, don't look at the orange light, or don't take the risk. That's exactly what we're currently dealing with in our country and in some parts of the world as well, where our perception of risk is not in the interest of supporting the broader community. That's the most diplomatic way I can say that. If it's just about us, without thinking about what the actions or no actions that I take or don't take will harm others, will put others at risk. So let's look at the first segment of what I want to share. So there is confusion what a pandemic is, and certainly the word pandemic or the term pandemic has been used in multiple ways that are incorrect. So I want to make sure that at least among us, we know what a pandemic is. So among us, there are 3 conditions for a pandemic to occur. It's a new virus or a cousin of a new virus or a niece of a new virus that our immune system hasn't seen. So it's like me coming back to you in a minute and putting on a black jacket. You haven't seen me in that black jacket. The second thing is it's easily spread from person to person. So it's not, even if I sit very close to Sandy, it won't happen it won't happen. But in other cases, even if I don't sit close to you, if I stand over here, my sneeze will go all the way to the end of this room and I can transmit that. And if it causes serious disease. So if this virus causes pain in my little toe, I really will take that. I don't really care. The key to the existence of a pandemic, when we declare a pandemic, is all 3 have to be in place. It's an and relationship. It's not the either or. That's often where the definition goes wrong. Okay. So let's look at the role of vaccinations. There are a number of those I shared with with your students, and maybe one of them, some of them will call me back because they think this woman has, some useful things to say. But I shared with them how I got into public health, from how I decided that missing the stethoscope around my neck is not a big deal. I started practicing as a physician in the Amazon rainforest of Suriname, where I come from. And the childhood vaccination rate was 5%. And no matter how smart I was, I was not going to fix that problem by myself. It was a real public health threat, kids were dying. And so I enlisted community leaders, nuns, tribesmen, midwives, traditional midwives, and together I brought them little igloo, ice chests with the files in there. I taught them how to immunize. I taught them how to drip the polio vaccine, Jonas Salk, in the mouth of little ones. Together, we changed that. We increased that rate to 95%. The individual medical model wouldn't let me do that. Do I use medicine all the time? All the time. I work with biomarkers. I do all of that research, but it is always with one goal in mind: is how do I keep communities healthy? Here you see a summary of selected vaccines and exemptions rules. So I'd like you to see the increase in exemption rules over time. That is not a trend that is sustainable to protect people. Because what we need to achieve is herd immunity. And herd immunity is the responsibility of each one of us. Because if we don't vaccinate, we won't go at a level that provides all of us protection. To have all of us be protected, for most vaccines and most viruses, it requires 96% coverage. Currently in Allegheny County, in other parts of Pittsburgh, we are below 96% for many of the vaccine preventable diseases, including childhood vaccinations in school-age children. And so it is our responsibility to get us to that 96%. Because there is a science around super spreaders. Let's say some of us are infected with XYZ vaccine. Now, I might only spread it to my two colleagues here on the front row, but you might spread it to the entire side of where you're currently sitting. So those are super spreaders who have that virus, the way the virus change has the propensity to spread out more. And we saw that super spreading with the first round of coronavirus infections, pandemic wave. So this is not a new phenomenon, but it seems that when the pandemic hit, the COVID-19 pandemic hit, we forgot, missed, ignored all of the signs. And one of the cardinal mistakes was that the pandemic was not led by public health. We know pandemics, and we were not in charge, at least not at the beginning. And so thank you again for masking, because you could see how different masks give you a level of protection. And so from no mask to a cloth mask to those blue mask to a proper mask as you're wearing an N95, that's how your protection increases. Risk perception. I don't know what you experience, but I mask when I fly still. I mask when I'm in large crowds. And people look at me as if I am the disease. I am the disease. I am the person who has the disease. You better go away from me. I said, no, you have to. I have also, just like I put people back into the restroom, I have actually offered masks. I travel with about 10 masks. I offered masks for people who are coughing. The flight attendant wasn't totally happy with me, but I am not only want to protect myself, I want to protect everybody else on that flight. So norovirus. You are not really well when you are infected. You're one with your toilet. That's basically it. And it can be prevented simply by washing hands. It's on the rise because we forget the very basic things that we do in public health. I share this I know a lot of you, and particularly also your PhD students, look into history to determine how the philosophy has changed. And so while in many kindergarten classes all around this country, all around the world, one of the key things that kids learn is how to wash their hands. When I see the practice or the behavior of adults, I wonder whether they skip kindergarten. It's not difficult, 20 seconds, right? You could say Mississippi 3 times or sing happy birthday 3 times to get the foaming and the full process going. So not difficult, yet we're seeing an increase of norovirus. Okay, so let's look at disasters. There is a difference between an emergency and a disaster. Certainly what happened 2 days ago was not, you could say, was it an emergency or what was it a disaster? And we can have a debate around that. But the key difference, just like an epidemic and a pandemic, the key difference between an emergency and a disaster is an emergency is something that we can control. If there is an emergency on campus and the campus police can control it, then it's an emergency. Now, if it is a disaster and the campus police can no longer control it, they need to have help from beyond Pennsylvania, then it is a disaster. So why is this important? Why? It's not a theoretical distinction. It's a distinction because when a disaster is declared, the federal government will then use that as a policy to release funds to that locality. What had happened during Katrina, and I'll get to that in a minute, is that while the governor in Louisiana declared a disaster, asked for an emergency declaration from the federal government, That declaration came much later. Then the supply that comes of emergency medications that comes to communities when the disaster is declared, went to other regions and other states before it came to Louisiana and to Europe. So a disaster and the management of a disaster has a cycle. That cycle begins with preparedness, response, recovery, and mitigation. Let me ask you, and I'm hoping maybe, I don't know whether they can text or listen, but certainly there are many of you in the room. Where do you think the US, puts most of its money? Which part of the disaster management cycle? Response. Yes, why response? Well, the response is correct, and why do you think?
Because that doesn't invest efforts in something that might not happen. I don't know.
Okay. So the impact of where you put the money is immediate.
Right.
Yes.
Right.
There is a response. The impact is immediate. Whereas in preparedness, you don't know whether it will happen or when it will happen. So in common terms, and there are adults here, right? Preparedness isn't sexy. But when you come in with all the supplies, that's you're doing something. So it's just like my world in public health. On a good day at public health, nothing happens because everybody's healthy. Well, we haven't had a good day at public health lately. How long does recovery take? In general? Days, months? What do you think? There are people in New Orleans who are still recovering from Hurricane Katrina, 2005. And the least money goes into recovery. We've had Hurricane Helene. People are focusing on Asheville, rightfully so, and then the wildfires happen. And we don't hear a lot, or we don't hear very much at all about how the people in Asheville are suffering because they've never had a hurricane before, not like that. So taking you to a new friend of us, well, actually a new enemy of us, the bird flu, H5N1. H5N1 is not new. I should take my words back. It's always been with us, only it changes the jacket. So there are cousins that are going around. And you could see where those areas are, where it goes around. So it's been here since mid-90s, mid to late 90s. It reemerged in 2003. It's called bird flu because we see it first in wild birds. Of course, we're currently deep into this H5N1. These are RNA viruses, and I want you to see that they're all around us in many animals, but also in us. There is a specific cousin of this virus. It's called the clade. And you see that birds in all states, including in our own state, are infected. So it is a matter of time. We have now, because of these infections, so from wild bird to domestic birds, have lost millions of poultry that poultry farms had to slaughter because of infection. We do not yet have it in cattle in our state. We're monitoring that very, very closely, led by our school and myself. I'm very proud and humbled to lead Pennsylvania's One Health Consortium of all academic institutions in Pennsylvania, focused on One Health. And so we're monitoring this very, very closely. So what's going on here? From wild birds through some genetic reassortment, changing of our jacket, gets into other birds that are closer to us, wild birds, geese, and then ultimately in even animals that are closer to us. In this case, the cowherd, that came to us via a truck with cows from Texas, spread to the rest of many states, as I showed you. And then ultimately, people were also infected. In this case, still other than one case, in this case, workers who were involved in those cattle farms. Now, you could ask yourself, what kind of personal protective equipment did the workers have? And if they had it, did they put it on? So occupational safety, I promised you I was going to come back to that, is what is here at stake. We did have one death in Louisiana, and that was coming in contact with a local poultry in the backyard from, of course, wild, in fact, it's in a wild bird to a domestic bird. Most recently, I have family in the Netherlands sent me an email that a fox in an area where water is being treated for drinking water was infected because, of course, foxes eat wild birds. So what does it mean for us? As you could see, all the animals that are currently infected, and this changes by the time I share this with you right now, there are more cases, and so this map changes all the time. But here's where I want to take you. We had not seen this prominent that cats get involved. And so first, there is a series of cats in North Dakota. And what we're currently seeing is the following. You could see the necrosis in the brain. There is a brain and liver, and so multiple organ systems are involved. But this is what is worrying to me. So in the beginning, all cats were dying. All cats who were infected were dying. Then some cats were dying and some cats were ill, but they didn't die. And now, some cats who are next to and in close proximity of infected cats don't get sick at all. So what's going on? We have another series of genetic reassortment happening. So there's another change of clothing. And as this change goes on, ultimately that will come to the general public. And that's what we're monitoring. And so I often ask people, do you cat lovers in the room? Because the advice currently is to keep your cat inside if you have a cat. This is the animal to human transmission again, as I mentioned to you, primarily workers. So the way the cats were infected from this contaminated herd was by drinking raw milk. There's also a theory that because cats are sloppy when they drink, is that maybe some of it went through the respiratory tract. So inhaling some of the milk droplets. Now, there are 14 outlets in the state of Pennsylvania who legitimately sell raw milk. There are people who think that raw milk is healthy, brings you back to nature. Raw milk can have, particularly of contaminated cows, can have this virus in it. So, of course, you boil the milk and then you drink it. When I was little, the farmer brought raw milk home and my mom boiled it, and that's what we used. So how do you, risk perception, remember that's how we started? How do you talk to people who are convinced that raw milk is the healthiest thing to drink? My students aren't here in the room, otherwise I would give them an assignment. So we're making decisions about what we eat and what we drink based on how we perceive the risk and how that risk has changed, how the philosophy around that risk has changed, and how the philosophy around the science that undergird pasteurizing milk has changed. So how natural is natural? This is Hurricane Katrina. This was actually the home from one of my faculty members when I was at Tulane. And surely there were physical impacts. You could see the mold on her walls, but there were also psychosocial impacts. One of my studies had looked at increases in childhood asthma, exacerbation, and asthma attacks in kids. And yes, indeed, there were 79, mold spores, and that's what I do. I count those spores. I analyze it and say, yeah, you're exposed to those mold spores. We'll see increases in children going with moderate to severe asthma, going to the emergency room with an asthma attack. But what we also saw in the data, that the number 2 reason for kids to go to the emergency room with an asthma attack was losing a pet during that disaster or changing schools more than twice. Psychosocial reasons. Oh, I should explain that, otherwise my kids will say, Mom, you did it again. Lust has nothing to do with sex. It is local leaking underground storage tanks. During Hurricane Katrina, several of those underground storage tanks with gasoline actually began to float. And that caused major leaks into the ground and into the soil and into the groundwater. So we talked about that, the prevalence. We created a community academic partnership because it doesn't matter what I think we should study, it matters what the answers that they want, the questions that they have. This is Hurricane Maria, 2017. I was involved in a study that looked at significant, from the National Academy of Medicine, that looked at significant morbidity and mortality after a hurricane. Now, the risk perception and the risk benefit is what I want to talk about, not only about how severe it was and how the community was for months without electricity and often without safe drinking water. What I want to talk about is when the aha moment happened in the federal government to send help after the declaration of a disaster, even after the declaration of the disaster, ultimately to send help to the people in Puerto Rico. It was because all of a sudden there was a discovery that almost 50% of the IV bags that we use here on the mainland actually were made in Puerto Rico. So did the help go to help the people in Puerto Rico or help us give people IVs on the mainland? So there was a special policy, and I've talked with the students about policy. There was a special policy of when you can give permission for ships to enter a port with emergency supplies. And that act, the Jones Act, was not activated until this discovery. So you see the shortage here. Yes, then other countries were asked to provide more, but by the time it took other countries, we're not very far from Puerto Rico. It took a simple implementation of a policy that was denied in the first place. here is a tribal nation that I've worked with for many, many years, the United Hova Nation. And here are the risks and the benefits that they had to, the perception of risk that they had to deal with. Their center where everything happened, from providing food to providing help with taxes, their center was damaged 3 times, completely damaged by subsequent hurricanes and floods. While that was going on, the young people left their family, and it's not a mom and a dad and 2 kids and a dog. It's really elders and multiple families together. They left to find jobs elsewhere. This nation, then of course, 2 things happened, 2 bad things happened. One, the elders stay behind and who would care for them. Secondly, the young people are missing the cultural enrichment and the cultural cohesion from the elders. This community was, and they don't want to call them that, were the first climate refugees of our country. The island was literally underwater. It was flooded. They could no longer live there. The government, both at the federal and state level, created a place for them to live without interacting with them, whether that was the right piece of land. And so you can fill in what happened. Did they move? They didn't. So they stayed on a part of land that was not yet flooded. Because that land, even though it was flooded, had significant cultural value. And that could not be recreated in a way that the government had envisioned that. Now, then afterwards, when there was this reaction, the government then reached out to involve them, but then it was too late. The plans were already drawn. So when we had 8 billion people in the world, I was asked what my priorities were. These are the 4: infectious disease, extreme heat, water and food security, and poor air quality. I take it that the air in this room is safe to breathe. I always ask my students that when you came up on the stairs or in the elevator, did you breathe? Because I don't. There are not enough people who care about health, air quality, both indoor and outdoors. And people always think that, and I could do a quiz here or there, that outdoor air is more contaminated than indoor air. Not true. And I come back to you of risk perception. When you have someone visiting you, you absolutely want to make sure that your house smells great. Particularly that the smallest room in your house, right? The bathroom, the toilet. Well, those air fresheners, those things that you put in the bowl and on top of the bowl, have volatile organics that are not good for your respiratory health. That very sexy and romantic bath that you take with candles, not good for your respiratory health. So now everybody's going to be mad at me. I didn't say don't take romantic baths. I just say skip the candle. So what's the science behind doing a risk-benefit analysis? It takes 4 steps, and this is a roadmap that we developed with the National Academy of Sciences. I was honored to be a member of that committee to determine what the risk benefits were of kids eating seafood. Kids 0 to 18 and pregnant women. In our analysis, we found that there is a minimal, just a minimal amount of seafood, fish that kids eat. And it was interesting because we had a public workshop and there was a question in the back that said, but could we count fish fingers? No. We don't know what's in the fish fingers. It looks like fish. I'm not sure what it is, but most of what's in a fish finger is the breading. Yes. And in the breading is oil. So by the time you get to the thing that looks like fish, I'm not sure how much nutritional value that is. No, we can't really count it. And so as part of that, that study, that 24-month consensus study, we came up with a way to look at risk-benefit analysis from a scientific perspective. And if you're going to, if maybe one of your students or the faculty here want to go back and look at risk-benefit analyses over time, and the philosophy around this is first, how do we perceive risk? And two, what's the science that's behind risk-benefit analysis? And it's not easy, it's very complex. But the first thing we want to know is the scientific principles around the risk-benefit analysis, are they sound? Are the methods sound? Have we looked at, this was the key new element that we brought, have we clearly looked at the science behind the modifying factors? Because the modifying factors, you'll see in a minute, are far more important than what the original issue is. And then what are the conclusions and recommendations, and what are the limitations? So that's the first step. If we say yes, then we'll continue to the next step of the process. If we say no, then we need to collect more data. We're suffering from another virus currently, and that virus is that we don't let science stay in the way of us making decisions or declarations. It's a bad virus. So then the next step is to look, in this case, it was for seafood consumption. It was, what is it that we know about it? How much are kids actually eating? What's the exposure? Because here's another risk-benefit analysis in a study that I have done in Suriname, is the fish, because of gold mining, mercury is used to release the gold, chemical reaction, and the mercury was not reabsorbed, but went into the surface water, went into the sediment. The plankton ate the sediment, the little fish ate the plankton, and the big fish ate the little fish, and the big fish is what pregnant women are eating. Now, the fish that, and we did a lot of analysis in the people and the fish and the soil, the two fish species that the pregnant women love most were the highest contaminated with mercury. So, from a public health perspective, what do I tell those women? Don't eat fish. That's their only source of protein, by the way. What do I tell those women? I did not tell them not to eat fish. What I told them is to eat their favorite fish, the size of your palm, once a week, and eat the other fish the other days. And sometimes they ate fish 3 times a day because that's what the protein had. Now, we are measuring the mercury over time. What do you think? What percentage of women you think followed my advice? Yeah. It's not, I'm not going to get an A for that advice. Let me just say, if I were to measure what's happening. And so we want to make sure that every step of the way, we use the best science that is, but we can't do it without the community. That's the community engaged piece. But here is where I believe the greatest contribution from our committee then did. It is on that bottom. It's the bottom row. It is looking at the contextual factors. Which people, which women, which kids are most susceptible, and we can measure that with biomarkers of susceptibility. Where do they live? Do they live on the West Coast? they have a different kind of risk if they live on the West Coast or in Alaska versus when they live in Louisiana. What's their access to healthcare to deal with the issues that then come up? What are the cultural practices when the Gulf of Mexico oil spill happened? The people had 3 questions around which I built a research consortium. Is the seafood safe to eat? Was question number 1. Question 2 was, is the air safe to breathe? And the third question was, what will happen with the health of the babies when the mom was pregnant during the oil spill? And so the seafood piece, we didn't buy seafood at the market. We actually, my team went shrimping with them and analyzed together in our labs back then what they caught and what they ate. What they caught and what they ate was not the same thing that was on the market. By doing that, we still showed that the cancer risks were below a level of concern. But had we not done that, we would never have gained the trust for them to believe that. And so cultural practices, social determinants of health, particularly, but ultimately it's about community resilience. And we talked with the students about that. So we can do as much as we want in the individual person or the individual child, but if we don't take that into account, we won't create a community, or in this case, a country that has kids to eat seafood that's healthy. Here's another example. We just finished and submitted a study in the Caribbean to look at the impact of smart hospitals. SMART is an acronym. It relates to making hospitals and other medical facilities, healthcare facilities, health services facilities, hurricane ready, hurricane strong, hurricane resilient. And so we were able to show that doing that, the facilities who were hurricane strong, who were renovated to be that, had a better continuation of service and health services, particularly also medication provision, than those who are not. You would think that's intuitively so, but by using data, we were able to show that, and that publication should come out pretty soon. So I want to talk about public health, and often I need to watch my time. Yes, I'm good.
Oh, yes, you're fine.
Okay. What's public health? And I won't ask you that question because I'm hoping you know the question. You're at the University of Pittsburgh, you must know the question. We're 77 years old. The School of Public Health is. But when my then 5-year-old was asked what her mom and her dad do, and kindergarten teachers do that to you. And she said, my dad is an engineer and he builds bridges. That was easy enough. Right? Then comes mom. Mom is a doctor, but she doesn't work in a hospital. She has a big computer on her desk. Remember those late mid-80s? And lots of paper. And they all say draft on them. She could read. So this was CDC, and we had lots of drafts before we come out with the policy. But public health is really about this home. Most money, most funds go into individual programs, whether it's HIV, maternal and child health, et cetera, et cetera. Very little money, although it's very important, go into the living room, the kitchen, and the dining room. Epidemiology, laboratory, for us to be able to measure viruses, measure what's going on in people's body, and surveillance to continue to monitor. We've seen what happens when we don't monitor the pandemic. But the bottom, the floor of the house is the most important component of what public health is. That's a public health infrastructure. If you don't have enough people and enough competent people, you can't do the work. If you train and educate the people, but you send them in a setting where they cannot do the work, where they can't perform, then you've done nothing. That's the organizational capacity. And what's critically happening now that I am worried about is access to data and systems data. If we don't have data to monitor, if we don't have agencies providing that data on a regular basis, we don't know how to act. We don't know what our workers need to know, and we can't function. And so we could put whatever resources we want to help individuals with maternal child health and HIV and malaria and disasters. If we don't build the floor of the house, this house will fall apart like a deck of cards. Yes. At least, even if you're in the department of, the philosophy of science, I should be able to stop you at 2 in the morning and ask you this question, and you should be able to explain this to everybody. It's not that difficult. The estimate of healthcare costs in our country for this year is $5.3 trillion with a T, 5.3 trillion. Less than 1% goes to the floor of the house. Those are real data. So here's the bottom line. We are pretty good in medicine, and we're getting even better to deal with genes, genetics, omics, all of those. We're very good at that and getting better. Precision medicine has made tremendous progress. Here is 95% of the impact in how we relate to our environment and the exposures, how we look at an individual not as one point in time, but over a lifespan. What we do as a 5-year-old and a teenager depends on what our health is at 80. And what the modifying factors are, the moderating factors. Remember, we talked about that. And so it's very simple to see how we'll get healthy communities. Do we continue to put 5.3 million in the 5% and address 5% of the risk? Or do we fund to address the 95% of the risk? Or do we address the 100% of the risk? Now, in public health, in a school, our School of Public Health, we do both. So bottom line, risk and benefits are interconnected, right? You make a decision. Voluntary risks are more acceptable than imposed risk, we know that. And risk perception influences the action to no action continuum. I'm looking forward to interacting with you. Thank you.
Very much. I will call on people so you can.
Yes.
All right, thanks so much for that really enlightening talk. I want to ask you a little bit about your thoughts on the role of framing the appropriate comparison in risk-benefit analysis. So
Framing the appropriate comparison.
in risk-benefit analysis.
Aha, yes.
So you talked about seafood consumption, maybe work with that example. And I thought, well, what you mentioned when it came to cutting down versus eliminating a high mercury fish, eliminating. So you might argue that a risk-benefit analysis is only useful if you appropriately choose the alternative, the contrast. Right? So how do we go about thinking about what the appropriate contrast is in the analysis, and in particular, maybe what is the role of the community that you're trying to make the analysis in order to benefit? What is the role of the community choosing that comparison so that you can frame an analysis that's most?
Yeah, that's an excellent question, and thank you for reminding me to tell you fuller story of in Louisiana. And so when the fish, when the risk perception, when the fish was contaminated, that the perception of the women, and some fish were indeed contaminated, but not at the level where we, at least for the pesticides that we looked, the contaminants that we looked at, not at that level of concern. The community did three things that were all negative. In their way of thinking, they switched to red meat, and they switched to contaminated fish, imported fish were more contaminated than the fish where they used to fish. So that was for them their comparison, but it took us analyzing what they actually ate, not what they sold on the market, to have them change that comparison to what they're familiar with. But it took that to change that comparison for them. But their comparison framework was, okay, so no fish, just meat. No fish that we catch, just imported fish. So the community plays a critical role in that. And you could, I'll tell you another not really story because it happened. We had a meeting in the community, and members of multiple federal agencies were there. And one federal agency representative was explaining what the risk was using a risk assessment analysis, and said, okay, so to use absolutely to your point, from a comparison perspective, said, in general, the US population, on the average, eats 13 grams of shrimp per day. That's about 4 shrimp. Upon which a Vietnamese fisherman stood up and said, are you saying 4 pounds of shrimp? Because we don't eat 4 shrimp on our shrimp board. Comparison right there. Because they eat 43 grams at least. And the other part of in the risk assessment equation was that the standard, the comparison was a 90-kilo white male. The Vietnamese are about 60. So the risk assessment, that probability assessment, was wrong in 2 places. That was the representative, and you can't blame the person, but that was the reference that they had, using a comparison that was absolutely not fitting in the community of concern. So again, using local community data to make it happen. Thank you so much for asking that question, because I could put more context onto it. You had a question in the back? Yes.
Just because it's so hard to find.
Say that louder, I'm
It's
sorry.
so hard to find eggs these days.
Eggs, yes, yes.
About the risk benefit analysis, when they called poultry farms because of avian flu. And is that, I'm just interested in the thinking there. Is that just based on a rule that was established by whatever the relevant government agency was that just triggered this event in terms of just taking out chickens? Or was there, in this case, an actual assessment of this particular instance? And then how did that risk benefit analysis go?
Yeah, that's an equally excellent question. So the Food and Drug Administration recalls eggs and butter and all sorts of things, right? And so they have 3 different levels of risk. When they do a full recall, that is they only do a full recall when people have died from eating X, Y, or Z. And so it's important to read what the levels of recall are. But in the case of eggs, I am always worried about eggs, because on the shell, unless they really wash it well, it's still salmonella bacteria because of the feces. In this case, the worry is that the H5N1 would be passed through to that. So if you want to eat eggs, my advice, and I'm on the, public health side, where if you listen to my kids, they always say, "Oh, don't listen to mom. Just go right ahead and eat XYZ." I would eat eggs that I make myself. I would, if you're making a fried egg or whatever egg, I would wash really very in warm water the shell. I would break the egg in a separate bowl, then right into the pan when you're making your omelet. And I personally would not eat a raw egg or an egg Benedict, or I would really from the egg.
But I'm asking.
I'm currently
about
not eating
I'm
eggs.
asking about the fact that a lot of chickens were slaughtered.
Yeah.
So maybe-
Yes,
And
but
what the thinking was behind that, whether there was simply a policy that was triggered, because the policy was established, let's say, 10 years ago.
Yeah.
So was it a policy that had a triggering condition?
yes,
And
there is a
so-
policy that
Or
triggers,
was
but it
an
is based
assessment
on
of the
facts.
actual
It is
facts
based
of
on
this?
facts, yes. It is based on facts and and that's why the surveillance effort that's what surveillance is so important. So where the domestic poultry is infected, has H5N1, is infected with the best strategy to deal with that is to slaughter the entire flock. That is the scientific best way to do that.
The fact that you detected in the population. The mere detection of it triggers.
Yeah.
This policy.
Yes.
That's.
Triggers the action, triggers the policy of triggers the action of slaughter. Yes, because it is so easy, not only within the flock, within that particular farm, it is so easy also to transport it to other places, as you saw on the map, because chickens are live chickens, slaughtered chickens are transported all over our country, going internationally, and that goes also for imported meat. Yes, it triggers slaughtering the entire flock.
So the poultry farmer didn't get to say, "Oh, that's a huge disbenefit to me and to the consumers like us who go to Trader Joe's."
Yeah.
You know,
Ultimately, it protects the farm long term, but it also because the policy is of course to protect the consumer, but I know where you're going and you're absolutely right, because when H5N1 in some other not in Pennsylvania, in other states happened, and they had to slaughter all the cows. I know from a colleague veterinarian who's whose veterinarian colleague surfaces another farm in another state where that has happened. That farmer committed suicide because of the implications economically. Yeah, those are decisions with significant impact. And that's why the case of prevention and monitoring is so key. The case of there are farms here in our state where the farming is fully sustainable, cow farms, where the farm is where there is minimal interaction, everything is automated, and that's better way to go. But then you have to have the money, right? I mean, I'll say it for you or for others to be able to have the investment to have a farm that's fully automated, right? Fully sustainable. So it is. It's not easy, but it is the policy that once you have an infected set of chickens, you have to sacrifice the whole.
Thank you for your talk. My question goes back to your nearly last slide where you have the gap between the 5% well-funded
Yes.
and the 95 not so
Yeah.
much funded. I just wonder if you could say more about the reasoning behind that gap, because it is clear that there's a monetary benefit in developing new drugs and whatever, but 95% under-financed seems an awfully unreasonable amount not to put investment in, so.
It is not like that in many other countries. In many other countries, including in Western European countries, it is, most of the funds go into, yes, some funds go into the individual efforts, but most of the funds go to societal efforts. That's why you have cradle to grave care. I mean, I'm part Dutch, so you have cradle to grave care there. That's why you have dental care. That's why you have the requirement are strict, but then you also have 70% taxes. So
Yeah.
yes.
I come from a European country, so I just was wondering.
Yeah, that's, so it's, public health is not seen as, it's not sexy. It's not seen as why you invest, because the impact is not as tangible as building a new hospital and putting your name on a building or a hospital.
It's a long time.
Correct, it takes a
Perspective you need
long
to-
time to come, yes. David?
So my question was also on that slide, but it's just a question of clarification. I wasn't sure how I should interpret that 5%, 95%. Could you say a bit more about what those numbers mean and where they come from?
Yeah, those numbers mean the level of risk. And so the level of risk, the bottom line is the level of risk is not commensurate to the level of investment.
Right, but I'm saying when you say 5% is this and 95% is this, what is that? Is that percentage of mortality?
No, it's a risk to your health. So risk, so the impact of investment.
Right.
The impact of investment in the individual versus the impact of the investment in from a community perspective.
So can you tell me how that's quantified? Where does that 5% number come
In terms of how we look at risk. So for example, if you have, and I share that example with our students, if you have a diabetic patient and you prescribe insulin, but you send the diabetic patient home in a neighborhood or in a community that's not walkable, in a community that doesn't have grocery stores where you could buy healthy food, then you'll continue to prescribe insulin. Ultimately, that patient most likely will go into renal failure, gets into dialysis. And so while you're trying to treat the individual, the disease progresses.
So I understand the qualitative point. I'm still trying to understand where this quantitative comes from. What are those percentages of? Is that percentages of what
The overall risk to health.
like the risk isn't structured that way. I mean, do you mean 95% of deaths are attributable to the fact of 5%?
I mean, this discussion is exactly why we have such a problem, because you can say, well, it's the kidney here and it's the liver, the kidney, and the brain there. That's because we continue to look at things through the individual model, medical model way, and that's not the way to look at
Forgive me,
it.
I'm just asking a mathematical question. I literally want to know what 5% number means. Somebody else said, it's 15%, somebody else said 2%. What do they disagree with? Or should I just take that 5%, 95% as figurative?
And in a bigger picture, yes.
So, but it's not quantified. I shouldn't take the actual number seriously. I should just say this is important, this is less important.
I think you should say this is important and this is less important, but I'm not worried whether you say 90 or 10 or 5 to 95.
So those
I'm
numbers
making
are just
the point.
made up to be
Correct.
illustrative. They shouldn't
Correct.
be taken literally.
Yeah.
So I had a question, which is about, I mean, in a way, you talked about the role that individual communities, their values and their perception of risk was essential to modeling an effective policy to address these various kinds of health risks. But I'm wondering whether it's not just their views about their own day-to-day assessments of what's happening to them, but the question's coming from here. During the pandemic, there seemed to be an increasing lack of trust in the sciences of epidemiology and the sciences of pharmacology, and so whether or not so I'm wondering whether the individuals whose values at the value side, right, has to take into account individual assessments, different communities, different cultures, different patterns of life. But how do you take into account different assessments of the science that generates the risk analysis at the end of the day, that then they're supposed to agree to the endorsements or the strategies that are determined to be the best strategies when they don't trust the science that's generating them.
Yeah, and that's one of the key, thank you, that's one of the key questions, that's one of the key issues we faced during the pandemic. And that's what we try to address with the seafood consumption, is to look at all the data that are, all the ways to do a risk-benefit analysis, which we did. We looked at a European model, a US model, an old model, a new model, a government model, an academic model, to ultimately come up with this roadmap. The challenge we had during the pandemic is the movement towards anti-science. So even though we had the facts, it was very difficult to have them consider, because then you'd have to say, okay, so we are increasing the value of issues that are not science, that are not evidence-based, and then we're going to do the comparison and say which one is right. I think we would then be diluting the science as we have it. That's the issue. So the movement towards anti-science has really impacted a lot of areas, not only vaccines. I don't know whether we had, we gave the Potter Prize, an award for health promotion and disease prevention to Peter Otis, and Peter has a book that really eloquently addresses that, the deadly rise of anti-science. He talks about the link of autism and vaccines, and used his own child to say, my daughter did not get autism from being vaccinated, and published that. It's pretty convincing.
Well, recent events like this week, like yesterday, like today on Capitol Hill are putting us in a situation perhaps around public health that is going to be a new environment for doing the kind of work you do. And so I don't know, where's the confirmation hearing today yet? No, was it confirmed? Okay, so they're, they're the head, as you know, they're whoever is in the head of the agencies, which because you worked in those agencies, has some control over what money is spent and what things, especially what information is dispersed, right? So I'm wondering how, maybe this is an unfair question because it's a tough one, but how the community of epidemiologists are facing, or what are the strategies for facing a new political cultural environment for doing your own work?
Yeah, I will not go into politics, but science has always been our neutral broker, and that's where we need to keep our eyes on. We will stick to our mission in public health, particularly in general, but it is the science that will ultimately prevail. And we wouldn't be swayed from the science. Now, we are facing, of course, a time of uncertainty whether that science will be funded, but that is our science, and that's what it's doing.
Is there, I can't see in the back, it's dark. Yeah, go ahead.
Thank you so much. There's a saying that would have been much more appropriate last week, but it gets used all the time. This is the worst week to say it. but the news media never comes out for the airplane that lands and doesn't crash. Once again, this is the worst we can say, but it happens every day, right? So we're talking about what's sexy and what's not sexy. That comparison has also been used. We don't report on the airplanes that don't crash. Right? So, and that's an older saying that has nothing to do with this week. It was just talking to last week. That plane had never crashed. Two very, on your slides, one's a very factual question, and the other sort of would like you to hash out a little more relative to some of the other ones you did. One is that on your list of pandemics, you very specifically put new virus. Now, one would also imagine that new bacterium could come along, but your slide specifically said virus. Is there any specific reason why it said virus and not pathogen?
So typically, most of the highly infectious and highly transmissible diseases are caused by viruses. That's why. But there is no specific reason. For example, when I practiced in the Amazon rainforest, we dealt a lot with malaria. And they are resistant to several anti-malarial medications now. So antimicrobial resistance is also something that's real and that we deal with all the time. But because most transmissible and most severe cases or cases with severe impacts are caused by viruses, hence that focus.
There's no reason in principle why there couldn't be a bacterial pandemic, but the likelihood is just.
Yeah, typically you could use cholera, but the mutations, one of the key reasons is that the mutations and the genetic changes in bacteria are not as fast and not as impactful as the changes in viruses, hence that focus. But yes, it happens with bacteria, it happens with parasites as well.
My other one concern, the one that you put up, the case study about the additive or preservative or something in leafy vegetables, spinach or something, and you listed that, you didn't sort of fully explain that, but would analyses of risk benefit here include the notion that leafy vegetables in general are good for children, but in this additive makes them more affordable, more preservative, even though there's this risk there? You didn't get into that one.
The packaging.
Yeah.
It's the packaging.
Okay. I mean, we would want everyone in general, especially children, to eat these kinds of things. But there comes with this, there's this additive, some sort of nitrate or something.
Yes. The other, one of my other studies, we've looked at the uptake of pesticides in vegetables, in leafy vegetables. Particularly one pesticide that can cause reproductive health effects and also impacts the neurodevelopment in kids. And it so happened, just like the example of the fish, the one vegetable that I was fed for years as a child was the vegetable with the greatest uptake of that pesticide. So again, you're facing it, do you say not to eat that vegetable or to eat less of that? And we're currently, from a public health perspective, erring to eat less of that, rather than saying don't eat that at all, if that's the only vegetable that the child likes a lot, that just kind of feed in, or, other vegetables. So it is, you could be way on the other side and say, I won't eat anything. I'm here to tell you that what says organic is not organic, really. But you could say, I'm going to spend all my money to eat only organic vegetables, or I'll just don't care. And in a way, we're somewhat in the middle, because there is no such thing as completely safe food. There is the lowest probability of risk and the highest probability of risk. And so that's where that's how you navigate it. That's why the risk benefit analysis is such a personal thing, whether you believe the science or not. You make that decision. I mean, everyone knows the risk and benefits of eating raw meat, but we all once in a while eat a filet mignon, yes? So we make that decision.
I think we're just about out of time, so I don't want to extend this too much. I was just thinking about, you and I talked about interdisciplinary interactions and contexts and thinking through these sorts of big, hard problems by bringing people into different spaces or bringing people with different skill sets into different spaces. And I guess around this problem of risk and risk perception, what like I'm asking you to think imaginatively. What kind of skill set would you want someone who's going to be making these policies in 5 years or 10 years to have in terms of the sort of interdisciplinary
That's a
toolkit, like,
really good question. Thank you. It's not only good, it's good for us going into the future together. The person should have to be transdisciplinary and having the skill set from this department, and knowing about the history, knowing about what the thinking is in terms of where the science is going, and knowing why pharmaceutical companies invest in X and not in Y, because that influences what comes on the market, right? And knowing public health and medicine, but also knowing biomedical engineering. Where are we going with advances in technology? How are we providing telemedicine or telehealth? And so it's truly transdisciplinary, and it's too much to take it all in. But I think we as faculty do a disservice to any of our students if we stovepipe it. And that includes the PhD. We just don't, I mean, we're not preparing them for the real world, because the real world is not in these segments. Even if you work on a basic science and your only focus was on rats or mice or whatever other creature, it is about people ultimately. You know, I have faculty who work on the genes of ticks, but it is about Lyme disease ultimately, right? And so how do you bring those together is what we need to. Really, it's you're issuing a call of action to us to think clearly as faculty, as an educational institution, what it is we teach our future colleagues.
Thanks for your talk. So in the future,
Could you speak a little louder?
yeah, consent from in talking about communication with communities is consent from the public. I mean, in that case, it's already exactly consent.
So your question is, how do you use communication in a public health approach? Is that?
Yeah, it is required consent. If we're implementing policy, part of that, or is it? Is the
The informed consent is part of every study, but our obligation is to, I don't know whether you've seen, you probably have seen informed consents. They're not easy to read. It could be in a different language, particularly for if you work with communities with low literacy. So it is our job, or any HIPAA, where how often do we go into a clinician's office? I'm a patient too, and you just look at the HIPAA form and just sign it and just kind of get me out of here. What I'm coming here to work, but we really don't spend time to read it. So our obligation is to take that informed consent and make it not only understandable, but make it clear what the choices are and what you're signing up for. Literally, any study is voluntary. You have to explain it. As I shared with you earlier, will people, even though they can grasp the consent, will they consent to a study after they have accepted a bio that doesn't let them participate in a study that could identify an adverse health effect in the future? Those are all also decisions that are being made, no matter how clear your consent form is. The better way to do that So what I always do is actually discuss the consent form with the community, have a community advisory board and say, is this what we should put in the consent form? What is it that we should put more in? How do you present the consent? How do you discuss the consent form before you finalize the consent? Because if the consent form is not understandable or not accepted by the community, you'll never have a study. And so engaging community engaged science, citizen science, it's engaging the community at every step of the way. And that doesn't begin with implementation, it begins with design. Because you might want to look at X, they don't.
Okay, we have time. David, you would like to ask a final
At the
question?
end of time. And it sort of follows up a little from Sandy's question. How do you think public health will deal with situations where there's substantial scientific uncertainty? I mean, you mentioned masks, for example. I mean, even 5 years after the pandemic, that's proved extremely difficult to get high quality evidence of the effectiveness of masks. That's where it's let alone mandates masks. That's not to say there's high quality evidence that they're ineffective either, to say the evidential situation is extremely complicated. What's the right way to make policy and to communicate publicly in these situations of high scientific uncertainty?
Yeah, it's very clear that masks work, but it depends on what type of mask. It depends on when you have the mask on, and it depends on how properly you have the mask on. So masks work, but it depends on. So the challenge in public health versus surgery is if you go in and take the appendix out, you do it right, you got in 15 minutes, the appendix is out. There aren't many factors that influence other than your skills and have the equipment to do that. In public health, any of the public health measures, we can all teach each other how to wash hands, but it depends on you how well you wash your hands. And so those modifying factors that I talked about become so critical that you cannot say with 100% certainty if you only just wear a mask, it will work. It has other factors that relate to it. And that's what the challenge is for public health, both from a convincing perspective, as well as from a tech perspective. So is it real science? Because I can't actively accurately to the third decimal say this is effective. We know it protects. We have seen that. But can I absolutely say that if you wear a mask all the time, and any mask, it will work? It is about what you wear, how you. It is about the impact of human behavior, is what is so important, and is what is so critical, right?
So that's very much assuming that's an answer that assumes we have scientific consensus.
Yeah.
Now I don't and had a somewhat more agnostic take on what the evidence base looks like for elsewhere, but that's science. There are situations of high scientific uncertainty, whether or not that's one. And I'm still interested in what's the right way to make and communicate public policy in situations of high scientific uncertainty. I mean, we saw the very early advice that the public elsewhere in the it was extremely negative. That was shifted very suddenly. There's a fair amount of evidence that there's quite high confident public announcements, which then shifted had some deleterious effects.
Yeah.
You see. So what do you think, the benefit of the high scientific pandemic, what do you think the right way is to deal with these situations where science itself is?
Yeah, so the right way is to be open and honest about it, that you cannot say it's always 100%. The right way to do it is to address and be open about the uncertainties around it. But the right way is also to get communities to work with you to have the right behavior. So that's the only way to do it correctly. If you follow the public health prevention and intervention strategies, the chances are very high that you will get to the other side. For example, if you go through a pandemic if we follow all, if we vaccinate, if we mask, if it just take the last pandemic, we will get to phase 6 after phase 3, when there is human to human transmission. And so the challenge is we continue to look through the medical model or the engineering model or the model it's precise, it's black or white. It's not like that in public health. There's always a phase and a down phase. Dengue. Dengue is endemic in many countries. It will not go away, but with prevention and intervention activities, we can go from the epidemic phase to the pandemic phase. So there's always a hum in the background. It's true for malaria, it's true for many other infectious diseases, but it's also true for obesity. It's also true for cancer prevention. It's true for cardiovascular impacts, so stroke and hypertension and all those. So it is much more difficult. Public health is a much more difficult job than medicine, for example, or engineering in that discipline, because it depends so much on human behavior. It doesn't depend on human behavior whether we build a bridge strong enough for cars to go on it. We have good engineers, we have good material, we build the bridge, people go off. Unless they go off it or they jump off it, the bridge will function. That doesn't work like that. And that's the challenge. But what often happens, to your point, is that we speak and people hear a level of certainty that they're disappointed in because it's not that. Because there's always the chance, there's always that opportunity for, if you don't do it right, it happens. How long did we not have we not spent on saying that smoking is bad for you and smoking causes lung cancer? Took 2 decades. And there are still people that smoke. Took 2 decades. So did we communicate it well? Yes. Yesterday, we had a conversation with a group of us who talked about how effective is the advertisement. You may recall, here is, I think it's about marijuana or some other drug. Here is your brain, and here is that on your brain where the egg explodes. That's a very memorable advertisement and a very memorable communication strategy and message. Do people still smoke? Do people still use drugs? It's all about that human behavior.
So I think you're saying that the issue doesn't really arise, but in fact, is the public health community has settled command of science, and there is a significant gap in the community of science. It's 100%.
The public health community has to live with, and that's maybe unlike many disciplines, has to live always with a level of uncertainty. And we're okay dealing with that. It's just like in the emergency room, you won't wait till the LDH levels are coming in before you say, oh, I think this person has a heart attack. I should do something. You do something with 7 of the 10 facts that you need. And that's bold to be able to do that. It's easy to me to wait till the 10 facts are in and say, full evidence, now I'm going to do something. We can't do that in public. And it's not everybody, public health is not for everybody. It's an uncomfortable space to be in to work effectively in the context of uncertainty.
So if I can jump in, since so what I'm hearing and what I think is the case is that in public health, there are cases in terms of the uncertainty of the science. We're kind of always in that position to varying degrees as well. But there's this other source of uncertainty that kind of overwhelms it, which is the uncertainty of the way in which whatever level of support you have for a scientific view, like masks are effective at lessening transmission, it's kind of like the difference in between efficaciousness and effectiveness, which is how good the vaccine is. You can study in a laboratory, right, and get pretty secure results about what percentage of people will not get the or not suffer the bad effects of a disease if they take a particular vaccine. But once you try to export that into a social context, you face a whole bunch of other uncertainties that have a different source.
But you start with a vaccine, with any drug that has side effects.
Right.
So why do we accept easier the side effect of an antihypertensive medication than a vaccine?
Well, that's a good, so, yeah, so that, that's
Every
a good
drug has
test
side
case. So if you have two different scientifically derived medications, right? And one is accepted by the public and one is not, that's an easy place to
Yeah.
point out this difference of the different sources. The uncertainty of the effect now, not just on a single body, but the effect on the health of the population.
But I take the risk, if I have diabetes or I have hypertension, I take the risk of the side effects. And sometimes they're horrible, including death or cancers or horrible
pretty bad.
diseases. Because I want to address the main issue that I'm dealing with, the main health effects. So that's my risk perception. I take that risk voluntarily.
Okay, well, I invite you to thank Dr. Lichtveld for the discussion and the talk and to join us upstairs for a reception. So thank you very much.
You need to.
They'll look after that.
I'll be joining you for dinner, so sorry.